Hello and welcome to Cardiac Ultrasound here within your emergency medicine video series. The objectives for the cardiac ultrasound are going to be basically a review of cardiac anatomy and understanding of positioning of the probe, and obviously clinical uses of bedside echo in the emergency department. We're going to start with a subxiphoid or subcostal view, where our indicator is going to be a little bit inferior of the xiphoid process, kind of like looking up there towards your heart. And this is more of a anatomy image there when you see your beam kind of like dissecting the anatomy in that plane. And just as a review, what you're looking at on the screen would be on the superior portion of your screen, you're going to have the liver, and then you're going to have the left side of the heart inferiorly, the left ventricle, the left atria, and then the right side of the heart with the right ventricle and the right atria. And then obviously the valves of the mitral valve and the tricuspid valve. So if we look at it there on a clip, you see liver, then you see the right side of the heart with the right ventricle and the right atria, and then you see a little bit inferior portion of your screen, the left ventricle and the left atria. When we're doing the echo, we can obviously start with the subxiphoid, and then we can do the parasternal long axis view. And this is a, kind of the way the beam is, again, looking at your heart on the long axis. And probe positioning should be around the 4th to 5th intercostal space, and then your indicator should be pointed towards the patient's right shoulder. Okay, so let's review quickly the anatomy. If you think about it, the more anterior part of your heart anatomically is going to be the right ventricle. So that's what you're going to see on the superior portion of your screen. You're going to see the right ventricle, a little bit inferior portion of your screen, the left ventricle, the left atria, and then you should see the mitral valve and the aortic valve along with the aortic outflow tract. It's important to note that in the parasternal long axis, you won't see the right atria, okay? You see some papillary muscles and chorda tendineae. So again, indicator pointed towards the patient's right shoulder. And here's our ultrasound image. And again, you should be getting familiarized with the images. So top portion of your screen, remember your probe is over here. So anatomically, your probe is contact with the skin, muscle. So the more anterior portion of the heart is the right ventricle anatomically. And then as you go, your beam goes down, you have the right ventricle with the left ventricle, with the left atria, the aortic outflow tract. This is the descending aorta here. And then you have the aortic valve and the mitral valve that's actually open. And just let's see this image clip in motion there. It's a pretty good healthy heart. When can we do the parasternal long axis? So we could do it during the FAST exam. We could use it as our cardiac window. Why? Well, you might have a patient with a large abdominal girth, or you might have somebody that looks like that. And what's that? That's a lot of like massive amount of subcutaneous air, right? This patient obviously has a right-sided chest tube. And what happens is, if you remember, air will cause an artifact, and it won't allow you to see a good image of the heart. Happens the same when you're trying to ultrasound a patient with severe COPD. Those lungs are hyperinflated, and you'll get the artifact. But let's move on to the parasternal short axis. Okay, so you start with a long axis, and what we're going to do is we're going to simply rotate our probe. We're going to move in a clockwise direction from the right shoulder. we're going to rotate clockwise, and we're going to be pointing it towards the left shoulder. Okay. And what happens is we get a view that I call the avocado view. Why? Because it looks like an avocado, and basically what you're going to see is the right ventricle. It's very kind of triangular in shape, with a more circular left ventricle. And you can follow me there on Twitter at ERGatorUF. And if we want to divide the walls of the left ventricle in the parasternal short axis, we can definitely do so depending on the textbook and depending on which orientation and at what level of the left ventricle. You can divide the ventricular walls in up to 16 segments, and that's, you know, a little bit more complex. In general, we divide in septum, anterior, lateral, posterior, and inferior wall, using kind of the mnemonic there, SALPI. Again, some other textbooks and a little bit more precise way of doing this would be to divide the left ventricle in anterior septum, over here, anterior free wall, anterior lateral, inferior lateral, inferior free, and inferior septum. That's a little bit more, you know, complex. The concept that I want to give you guys is that when you're looking at the, you know, a parasternal short axis, that motion there, that should be equal. You're looking for, you don't want to see a segment that's moving paradoxically compared to the other segments, or actually sometimes not moving at all. And then you can get an idea of what part of the heart, what segment of the heart is maybe akinetic, and you can correlate that sometimes with the EKG. So parasternal short axis, let's look at the clip. And within the parasternal short axis, I want you to take a look at 3 areas there. You can see over here the heart, and those are kind of the levels that we want you guys to see. You have these are at the level of the papillary muscles, and you know, again, the left ventricle and the right ventricle. And if we tilt our probe, and that's kind of without moving the probe, and you'll see this more when you do hands-on, you want to kind of move the tail of the probe by keeping contact there. Instead of like moving your probe around, you're just going to tilt, so your hand is going to kind of rock backwards as you you start looking right from the apex of the heart, and you start moving towards the base. And so as you continue to move from the papillary muscles, you're going to see the mitral valve. And as a reminder, obviously it's a bicuspid valve. They call it to have a fish mouth appearance. So you're going to rock your probe, you're going to kind of look towards the base of the heart, and as you continue to move from the mitral, obviously the next valve that you're going to see right here is the aortic valve. And the aortic valve has has 3 cusps, and they call it sometimes they call it the reverse peace sign, the reverse Mercedes-Benz sign. But those are the 3 views that we would like you to see. And then we move on to the 4-chamber view, or at the apex of the heart, and this is sometimes a little bit more challenging to acquire. But you'll have the transducer kind of almost at parallel to the chest. You're kind of looking for the PMI, and kind of looking upward there. And this is the image that you're looking for. Your indicator should be pointed towards the bed or the left axilla of the patient. And reviewing the anatomy, this is the image that you should acquire. And you're going to have the left side of the heart on the right side of the screen. Left ventricle, left atria. and you're going to have the right side of the heart on the left side of the screen. Mitral and tricuspid valves. Okay, that's another orientation as we get ready to see the actual clip from our colleague here. And you have the left side of the heart, left ventricle, left atria, right ventricle, right atrium, along with the valves. And what we do sometimes here, if we're looking for pathology, we introduce the Doppler. And again, you're going to put the probe, again, that superior portion of the screen, regardless of what ultrasound you're doing, it's going to be where your probe is touching. So you're looking kind of from the apex towards the base of the heart. And red and blue, I think I've said it before, it's not arterial or venous. And that'd be kind of cool, right? But no, it's not. This indicates direction of flow. And if you think about, if you're a fan of Bart Simpson, Bart, blue is away and red is towards. So red is towards the probe, and if you think about it, you obviously have blood moving from the atria to the ventricle. So red towards the probe, and then blue away. It's going to move from the left ventricle outside the aortic outflow tract. So it makes sense. And basically, if this patient had a lot of mitral regurg, you would see a lot of blue coming back, and you basically don't. Okay. So red towards, blue away. So let's move on to some clinical scenarios here. Tamponade, obviously it's a clinical diagnosis, but if you have your ultrasound, you're obviously going to take a look at the heart. And in order to have tamponade, you need a pericardial effusion. And we've talked about fluid, and fluid in ultrasound shows as anechoic, having like sharp edges, right? So a common mistake that occurs when people are doing the parasternal view is that, they see a little bit of heart activity, and then they look at it. Oh, great, I'm looking at the heart. Well, you have to be really careful, and you have to be deep enough that you see, the pericardium. The pericardium down here is a very bright and hyperechoic structure. So you want to be deep that you see the pericardium, and if you don't, you could be missing an effusion down here. So you obviously have an effusion, right? We remember that the aorta, the descending aorta, it's kind of our landmark. So if you have fluid above the descending aorta, that's pericardial. If you had fluid down here below the aorta, that would be pleural effusion. And I've seen patients with both pathologies, but that's kind of our reminder. So the first thing is you obviously need to have an effusion. Okay, so this is a subxiphoid view. The liver is over here. The right side of the heart should be here, but it's kind of like non-existent, right? You do see the left ventricle, and there's a massive pericardial effusion. The thing with tamponade and effusions is that what causes the tamponade physiology is not the amount of fluid. You have patients that have malignancy, and they have chronic effusions, and you will be scanning them, and they'll say like, "Oh yeah, doctor, they told me I had fluid on my heart," and you'll be like, "Wow, there's a lot of fluid." But what causes tamponade is the rate of accumulation, not the amount. As little as 100 mLs of fluid around your pericardium can cause tamponade physiology. That's because your heart is not able to accommodate to the changes there in pressure. If you think about it, the heart is trying to fill during diastole, and the left ventricle, obviously it's more muscular, has more fibers there, so he's able to fill during diastole, but your right ventricle is definitely thinner, and it's not able to fill during diastole. So you have right ventricular collapse during diastole, and that's one of obviously the main ultrasound indicators of tamponade. When you look at the four-chamber view, for example, again, you see the left side of the heart over here, and then there's the right side's in trouble. Basically, you have right atrial and right ventricular collapse. When you look at the IVC, you see that there's an effusion. This is inferior vena cava. We know it's the inferior vena cava because it runs. You have a liver on both sides. That makes sense. So you're having an IVC that's basically non-collapsing, and we'll talk about it later. But basically, every time you take a breath during inspiration, there's obviously increased return to the right side of the heart. So basically, the IVC collapses, and that's a normal response when you take a breath. But in this case, the heart's in trouble again with tamponade, and you have a IVC that's kind of plethoric there. So you have the effusion, the IVC going to the right side of the heart. So again, ultrasounds as a review, ultrasound signs of tamponade, right ventricular, right atrial collapse, the dilatation of the IVC when with the no respiratory change. So another really important thing that we do when we do echoes is to look for left ventricular function. And the four things that we kind of look at here are the left ventricular wall thickening, the cavity size change, and the opening of the valves, right? So walls should thicken by about 40%. You look at the left ventricle, you want those fibers, you want that ventricle to increase by 40%. If you compare it to this one, this ventricle is barely kind of moving there. If we do short axis of the heart and we do M mode there, again, M mode motion in time, you have you can calculate, the machine will help you calculate if you measure left ventricular volumes during diastole and systole. The machine will help you calculate the EF. So another sign is the cavity size. Anything greater than 6 centimeters is associated with left ventricular systolic dysfunction. And if you look at this heart, this is the end diastolic diameter, and that's greater than 6 centimeters. It's barely moving. And that cavity, when you have that squeeze, when you have systole, should decrease by 40 to 50%. And a good healthy heart kind of looks like that. If you compare it to like this heart that's barely squeezing, heart that's in trouble. And again, you compare the changes in systolic and diastolic diameter, barely change there. Valves should open fast and wide. If you think about it, it's like a door that's being opened. If you have good flow, strong contractility, that valve is going to like open, and you're going to see that mitral valve. That's the anterior leaflet of the mitral valve, just hitting the septum there. It's good activity, strong heart again. And again, M mode, who's our friend here, through the mitral valve. This is the motion of the anterior leaflet of the mitral valve as it opens and hits the septum and closes and opens and so on. So compared to this other patient here, that basically that valve is barely moving, not getting close to the septum. And this is actually M mode, but we call this E point septal separation. And it should be less than a centimeter to be within normal ranges. So if we compare these two parasternal long axis view, you see on the left side there's low ejection fraction. Even if we don't give it a number, if we're doing a quick ultrasound in the trauma bay, you can quickly say this patient has normal ejection fraction versus low ejection fraction, right? Again, another view here through the mitral valve. This is kind of a severely reduced ejection fraction. We talked about it. There's the valves are not opening fast and wide. There's no changes in ventricular diameter. There's no thickening here, or what it's called fractional shortening. So another clinical use of ultrasound is very important. It's the pulmonary embolism, and there are 4 signs on ultrasound of pulmonary embolism, and those are right ventricular dilatation, right ventricle hypokinesis, tricuspid regurgitation, and abnormal septal motion. So the normal right ventricle size within the end diastolic diameter is more or less about 21 millimeters. And there's kind of a ratio of the right ventricle to left ventricle, and it's 0.6 to 1, but an easier way to remember is 1/3 is kind of right ventricle, 2/3 is the left ventricle. So left ventricle should be obviously more prominent during diastole. But in this case, for example, the right ventricle looks more prominent than the left due to increased right-sided pressures. This is a subxiphoid view of the heart. Again, right side of the heart looking a little bit bigger than the left ventricle. And also, one of the things that we look for during diastole, the septum, which is here, shouldn't be moving towards the left ventricle. It should be the opposite. The left ventricle is bigger, so the septum, when it moves towards the right side. So if you have a right side that's dilated and the septum is moving in the opposite direction, that's another concern for pulmonary embolism, septal shift in diastole. And right ventricle is barely squeezing there. A little bit of right ventricle hypokinesis. This is a parasternal long axis. So right ventricle, left ventricle, mitral valve, aortic outflow tract. This shows a kind of a dilatation there of the right ventricle. That's 3 centimeters. That's very prominent. Anything greater than 2.5 is abnormal. So this is 3.2. Okay. Another sign. This is from the Emory website. Is the movement of the interventricular septum and during the short axis view. If you remember, the left ventricle is really circular. Remember that avocado view, and this is triangle. So you have it. They call it a D sign instead of an O or a circular left ventricle. You're seeing kind of a letter D because there's pressures from here from the right side compressing on the septum. So basically, you have kind of the 4 signs. They have the D sign. You have the dilatation of the right ventricle, abnormal septal wall abnormality, and in this case also you have some tricuspid regurg. Part of the echo includes the evaluation of the IVC. We use it for during sepsis. We use it to kind of for fluid responsiveness on patients. And again, the subxiphoid view. When you're looking at the heart, what you do is from the subxiphoid, once you've located the heart, you kind of do a counterclockwise move, and then you're able to visualize the IVC. Again, we know it's the IVC because obviously it's going into the heart, and you have liver on both sides. So the problem is, first of all, make sure it's the IVC. If you're in doubt, you scan, right and left, and you'll see the aorta, towards where the aorta lies on the left side of the body. And then as you go more towards the right, you'll catch the IVC. It's kind of always visible. And the indicators to measure, any IVC diameters is at 2 centimeters after the atriocaval junction. And that's where kind of the guidelines of ultrasound from ACIP. And we use it for preload assessment. Like I mentioned earlier, when you're spontaneously breathing during inspiration, the IVC should collapse because of increased blood flow return towards the heart. If you're on positive pressure, if you're intubated, what happens when the machine gives you breath? It actually is the opposite effect because the pressure kind of prevents flow into the heart, so it's dilated. This is an IVC that's collapsing probably more than what we look to look at. The normal diameter is about 1.5 to 2.5 centimeters, and you can measure it there. You can calculate change. But if it's definitely more than that, you're probably looking at a patient that is septic, maybe in need of more fluid resuscitation. There's a recent journal in the American Journal of Emergency Medicine that kind of had an algorithm including the early goal-directed treatment of septic shock, and it included, part of the algorithm was to look at changes in the IVC. And if it collapsed more than 50%, you're getting crystalloids and kind of reassessing. And if it was less than 30%, then you move on down the algorithm of mean arterial pressure and so on. But interesting that the IVC is, one of our first non-invasive quick indicators. And in children, there's some literature that they try to look at for evaluation of dehydration. They've done IVC to aorta diameter and ratios, and they've correlated that. But basically, as a big general rule, you can look at the IVC to see if it collapses more than 50% or less than 50%, and there's diverse literature. So I guess you shouldn't take it as be the holy grail, and in the basis of your exam. The IVC should guide your treatment, not be like the final thing for you to do. Basically, any greater than 50% collapse, give fluids. So we hope that you have a good intro here on ultrasonography. And if you have any questions, you can email me. Thank you.